Everyone, and welcome to this week's COVID-19 office hours. I'm going to spend just a couple minutes going over some tech notes and logistics, and then we'll turn things over to our team at HUD and the presenters today. So first and foremost, we are recording the webinar as we do always for the office hours. We'll post a copy of the office hours recording along with the slides and the content from the chat to the HUD Exchange at the link that is on your screen right now. Just please give the team a few business days to post those materials. Also, if you have any trouble during the webinar connecting to the audio, we encourage you to switch over to the phone audio. You can do that at any time by dialing the numbers that are both up there on your screen, and that will be in the chat in just a moment. People are going to remain muted for the duration of the webinar, but we do hope to hear from you throughout through the chat feature in WebEx. To find it, just look in the bottom right-hand side of your screen, look for the word chat. And when you click on that little icon, it'll open up the chat feature for you. When you send in questions, comments, feedback in through the chat, just take a moment to make sure that they are sent to everyone. It should default to that, but if it does not, just take a moment and scroll down to the arrow on your right, and that'll let you select everyone. And with that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Programs. Norm?
Thank you, Natalie, and welcome everyone to the office hours today. We have some great stuff for you and some interesting stuff and a great community presentation. So welcome everyone. I'm going to quickly introduce the content today, and then we'll jump right into our presentations. So you'll be hearing from a couple of people from the SNAP's office, myself, and a couple others, and we will also be in the chat window answering any questions you may have. So please feel free to type in questions about the content we covered today or any other questions you have for us. We will try to answer as many as we can. We will hear a spotlight about some winter planning TA resources from one of our fantastic technical assistance providers, David Canavan. We're very, very pleased to have a community presentation from the city of Detroit. Tara Linsner and Stacy Conwell-Lee will be presenting that. They're actually going to present first, and then as soon as they're done presenting, we'll get our regular update from the Centers for Disease Control and Prevention. Ashley Meehan will be doing that presentation. We have several other really smart people here to help answer your questions. So again, please feel free to chat us any sort of questions you have or anything you'd like us to give you information about. With that, I'm going to turn things over to Tara from Detroit, and she's going to walk us through our community presentation. Tara?
Hi, good afternoon, everyone. I'm really pleased to be here. So my name is Tara Linsner. I am the Homelessness Solutions Director, and I work in the city of Detroit. Stacy Conwell-Lee works on my team, and she was going to present with me, but she's feeling a little bit under the weather today. So it'll just be me presenting, but Stacy is on in case to help answer any additional questions. Okay, so the first thing I want to talk to you is the city of Detroit has set up a separate COVID isolation center for individuals experiencing homelessness since the start of the pandemic. We've operated in a couple of different buildings, but the question was, how did we find the locations to operate a completely separate facilities for our shelter residents who were sick? And so we did not go into the hoteling, moteling option at all at the city, and there's a number of reasons that's particular to the city of Detroit. But in order to find these additional sites, we did a couple of things. The first thing is that we really engaged with our real estate team at the city of Detroit to say, like, this is your realm, this is your expertise. I don't know how to search for units outside of Zillow, and that's not going to cut it here. And so, how can you help us? And they were able to engage with different brokers, with different city departments to really kind of scour the city and say, like, these are the units, these are the buildings that we have available right now. And then my team, the Homelessness Solutions team, went out to see if this would work for an emergency shelter site. Did it have enough bathrooms? Did we have the ability to isolate people who we knew were COVID positive? When the pandemic first hit, we did both a quarantine and an isolation site. And so we needed to have that separation for people that were just symptomatic, but we weren't sure if they were COVID positive. And as the pandemic progressed, the access to testing really increased. And so we were able to switch to a complete isolation only site. And because those people who were ill, we were able to get testing done pretty quickly to figure out if they had COVID or not. And then the final thing we did was talk to our existing providers. Some of our providers have 10, 12 different programs and are pretty big. They're spread throughout the city of Detroit. And so we reached out to everyone and said, this is what we're looking for. We want to, do you know of anybody? Do you have any donors that might know of anybody that has a building that we could access? And so we really just kind of put the word out as far and as wide as we could, just to see what we could get. So next slide, please. So we ended up with two main locations. The first, when the pandemic first hit, we used an existing shelter site. We had an emergency shelter that actually had another building that they could move their shelter program into that allowed us to operate our COVID isolation shelter in a completely separate building. And that was just through negotiating with an existing provider. I mean, all of our shelter providers knew how critical it was going to be to get people who were sick out of a congregate setting and have some place where they can recover safely. And to keep both the other shelter guests and the staff safe. And so we were able to kind of work out a plan with an existing shelter to use one of their facilities in a different way. That lasted for about 6 months, and then they eventually needed their building back. And so then we transitioned to an old nursing home. The nursing home worked out really well for us because it had recently come offline. It was ADA accessible, so we didn't have to worry about individuals that had mobility challenges to be able to serve them. It was set up for good supervision, right? Like people could easily see what was happening on the floor because that's usually how nursing homes are set up. And it had the bathrooms that we needed in order to accommodate folks. It also had a full kitchen, so meals could be prepared on site, and laundry facilities. So everything was already there and the building was already set up that way. It even had the furniture left over from the nursing home. And so we were able to very quickly move into that building. We had to do some IT stuff, some basic stuff, but it already had admin offices. I mean, it was move-in ready, basically. Understanding that there's not, move-in ready buildings throughout every community, but we got connected to this nursing home because of one of our existing service providers that had some different kind of programming, and they knew somebody who knew somebody, and that's how we were able to access the site. And that's where we're currently at right now. We've been there for over a year, and plan to continue services for as long as we're able to. Next slide, please. So this is a picture of the current site. It's operated so let me back up a bit. Again, when the pandemic first hit, we had the Detroit Health Department help operate the location. We transitioned to a nonprofit provider, the Detroit Rescue Mission Ministries. They are right now operating the COVID isolation site. So the health department isn't part of the day-to-day operations anymore. We currently have planned for it to operate until April of 2022, and then Omicron hit. So we're going to try to see if we can stretch that out until the end of September because that's how long the ESG-CV funds will be available for. Like I said, it's isolation only. The original capacity of the building was supposed to be 60 regular beds, 20 overflow. Right before Christmas, we said, you know what, purchase 50 cots. Just do it. Because it's an isolation only site, we can have multiple people in one room. And so they purchased 50 cots, and it's a good thing they did because we've been seeing a huge spike in the number of people who are COVID positive. And so we've been averaging about 100 people a day. Next slide, please. This is just a quick slide about vaccine and testing clinics. We have on-site vaccine and testing clinics at our emergency shelter, so 19 different sites. That is being done through the health department and our Michigan Department of Health and Human Services has a private company that goes out and provides those services. Most shelters have access to vaccines and testing at least twice a month. And right now with Omicron, we're trying to increase testing frequency as well. The health department also began distributing Binax antigen testing kits to our emergency shelters and our outreach teams, which has been super helpful because shelters have been able to actually test folks at entry. So when they get a new referral, they test them before they do go through their full intake process. And if anyone is COVID positive at that time, they just make a referral to the isolation shelter. And so that way they haven't gone throughout the entire building. They haven't gotten settled, talked to other residents, went to the common dining room. They have, they know at entry. And so we're able to get them to the isolation site until they're no longer contagious. Year to date, we distributed almost 2,500 of those testing kits. Next slide, please. So just to give you an idea of what COVID has looked like in Detroit for our homelessness population. So in March of 2020, we basically served just under 450 people. These numbers also include family members who may have tested positive, one person has tested positive, but might have minor children that can't go stay with friends or family and have to stay with the household, or the child is positive and the parent has to stay. And so it's not 450 of people who have tested positive for COVID, but have had at least a family member test positive as well. And then, as you can see, is 2021, our numbers were a bit lower. But then in October, you can see that in the last quarter of 2021, we almost doubled what we served in the first 3 quarters. So this is really a result of Omicron hitting. And then January has been an exciting month. The first 12 days of January, we've served almost half of what we served last quarter. So we have seen an extremely sharp increase in the number of people that need to isolate at this center, and it's nothing like we've seen before, right? We never expected to have this many people test positive, and so that resulted us to circling back to our health department to say we need help. We are, at times over double capacity what we initially anticipated, and we have to do something. We have to do something different. And with this guidance that's come out from the CDC, can we do more of a testing out strategy? Because we have, since the start of the pandemic, we've had multiple health threats, right? That we provide a public health service by able to give people beds so they can stay indoors and not have to sleep outside. At the same time, we also have to realize that in Detroit, the majority of our shelters are still congregate, and by putting people in congregate settings, COVID will spread more easily. And so, what can we do to get people out of our isolation shelter as fast as possible, but it's also safe? And so we recently, this is all in January, in fact, it happened last week. We worked with our health department to develop a different strategy for our isolation shelter. You can go to the next slide. And so we developed this flow chart. So basically, we are going to be testing asymptomatic people at day 5. And if they test negative, we will be able to exit them out of the isolation shelter, and with instructions to wear their mask until day 10. We recognize that some people are still not going to wear their mask until day 10, but considering that we only have, considering that we simply don't have the room to safely house everybody, and they've had that negative test, and they don't have symptoms, that's what will happen for asymptomatic folks. If the asymptomatic person tested positive, they'll continue to isolate for an additional 3 days. Symptomatic people will test at day 7. If they have symptoms, if their symptoms are still remaining, then they're going to stay until those symptoms lessen. But if they have improving symptoms or they're fever-free and they're fever-free for 24 hours, we'll test them. If they're negative, on day 7, we're going to exit them out. If they are positive, they're going to continue to isolate for an additional 10 days or for an additional 3 days. And then for our families where we have mixed status, one individual tests positive, or one individual is positive, other family members are negative, we're going to keep them for 10 days, test the entire family at day 10. If they're all negative, then they'll exit out. If one person is positive, then they're going to isolate for an additional 10 days in order to make sure that individuals who that if it spread within the family, that we're allowing enough time for them to isolate without releasing them while someone may still be contagious. So this is an overview of what we're doing in Detroit. As usual with this pandemic, we're always trying to shift and do things a bit differently as the pandemic, COVID keeps changing on us. And so this is our newest planned testing strategy. We'd be happy to share this strategy. We're just waiting on the final signature from the health department, and then we'd be happy to share it out. There's about a 4-page document that talks about based off of different shelter layouts and how people configured what to do. And so we just put together this flow chart to kind of give it a very simple decision tree for the staff that operate the isolation center. And that's, Norm, I'm going to turn it back over to you. That was everything I had.
Thank you so much, Tara. We do have a couple questions I wanted to run by you. One question was about staffing the isolation center and any challenges with staffing the isolation center. I can imagine people, it's not their ideal, workplace. So can you talk about some of those challenges and how you overcame them?
Yeah, that's a great question. It is a challenge. Stacey, I saw you came on camera. Do you want to answer that question?
I'd be happy to. Please forgive my my voice. So as we saw Omicron sort of taking over, one of the things that we did was talk to our provider, and we said, look, this is coming. It's going to happen. You need to staff up because your staff are going to get sick. You need to be prepared. You need to bring them on. So we sort of anticipated this before the holidays, and we're so grateful for Rescue Mission. They did that. They brought on almost a second team. They really deepened their bench for us so that they could handle the influx that we knew was coming. And they ordered the cots that we knew they were going to need, and they made sure that their facilities person was ready to go, because that building was probably not designed to handle, bathrooms and electrical and whatnot for all of those people. But they're just doing a super job. I hope that helps.
Yeah, and Stacey, I just want to add to that. Oh.
Yeah, please go ahead.
Sorry, no. I just want to add to that the use of hazard pay, the use of those incentives, because we do recognize that, it's one thing to know that COVID exists and it's out there. It's another thing to know that the person that you're working with and standing in front of you has it. In some ways, though, also, at least that person does have it, and you're going to take the proper precautions to keep yourself safe, as opposed to sometimes you develop this false sense of security. You kind of get into a groove, and you forget that just because this person tested last week doesn't mean that they're completely free of COVID today, and so that you always need to be diligent about personal protective equipment. But yes, the hazard pay, incentives, those things have been very helpful as well.
So I'm glad you brought up hazard pay and incentives. Can you talk about what incentives have you found that people have worked with people? Is there anything sort of unique, or I don't know, what are your observations about what kind of incentives people should be trying?
So what we have seen is like a bonus with each check that people have been getting for frontline staff in particular, even admin staff that have to fill in for frontline duties. So kind of, switching, like usually you're the billing person, but now you need to sit in the security booth because everyone is sick. And so recognizing that even though somebody may be salaried or in a different position, that they will get this hazard pay for doing this work, has been one thing that we have seen. Stacey, have you heard anything else from our providers?
I think you've hit it right on the head. That's really what we're hearing, and even at that, it's tough to get people. We hear it from all of our providers. It's tough to get folks hired and get them to stay. It's a tough time for everyone.
Yeah, absolutely. So we have another question about legal liability with respect to operating an isolation shelter. Can you talk about like how you all think about that, and like, do you have special insurance for that? Is there sort of a duty to provide certain kinds of medical assistance? How does that part of this work?
Yeah, so I'm not sure if we're doing, well, you know, there may be things that we're missing, but I'll tell you what we're currently doing. So in terms of liability, we have a process that if someone who's COVID positive leaves the isolation shelter, there is a notification process so that the health department can be aware of that individual. So there is like a notification process that does go out, because we don't want someone who's COVID positive going to another shelter and unknowingly, you know, impacting, you know, affecting others. So I can't speak to like the different kinds of insurance. Our provider really handles that side of things. In terms of medical care, so when the isolation shelter was being run by the health department, they had RNs on site to do that work. When that had to stop, they don't currently have RNs on site, but they have. Actually, Stacey, you want to take answering the question? You know more about the day-to-day operations than I do.
Sure. No, I'd be happy to.
Okay.
There is a physician that is on site. They additionally have CNAs helping out and doing testing. And they have their staff are doing regular wellness checks on folks to make sure that everyone's doing okay. The doctor does sign a letter saying that the person has has spent their quarantine, their isolation time at the shelter, and that they have been cleared to leave. So that's a way that other shelters can know that this person has been cleared to leave and they are safe to admit into the regular shelter.
And one last question I wanted to ask was about, have you all given thought to how long you plan on having this sort of process in place? Do you have sort of a time frame in mind, or are there sort of benchmarks you're looking to hit before you sort of go back to, I don't know, your previous process?
Yeah, that's a great question. So we honestly haven't gotten that far. I think that if our shelter can get back to its capacity or under capacity, I think we could start implementing that. One of the things I didn't mention is that even with this, even with adding additional beds and having this new testing procedure, we still have had our more non-congregate shelters have to isolate folks on site. And so we have 6 shelters right now that, even though we have an isolation shelter, even though we're trying to get people out as quickly as possible, we can't keep up. And so those shelters are isolating on site until our capacity we can decrease our capacity enough to open it back up to everyone. So we're right now still very much in the middle of it. We haven't started to think about what would be the trigger to go back to our 10 days, but it most likely would just be our occupancy levels.
Great. Thank you so much. That's a fantastic presentation, and we definitely appreciate you sharing like your process and how you're thinking about this and dealing with some of the challenges that everybody is really struggling badly with. If you have any questions, please feel free to type them in the chat window. Otherwise, we'll go ahead and move on to our next presentation. We're going to have our CDC update. Ashley Meehan is going to present this for us. So Ashley, I'll turn things over to you.
Thanks, Norm. Hi, everyone. My name is Ashley Meehan, and I am CDC's Homelessness Unit Lead for our COVID-19 response. So it's good to be with you all today. Next slide, please. All right, so this is what cases have looked like in the United States since the beginning of the pandemic. We can see a decent-sized peak about the middle of the graph, which was our December 2020 to January 2021 surge. And then a little bit later on in August or September of 2021, we see the Delta wave. And then we can really see on the right-hand side the number of cases sharply increasing. And that's where we're currently at with Omicron. So recently we did have over 1 million cases in a single day. And I don't know that we're reaching our peak yet. It's too early to say. So let's keep anticipating that cases will continue to increase. I'm sure you're all feeling the weight of this. You know, I look at this graph and I'm like, wow, this is really striking. But then I also look at my own life and I'm like, okay, so many people that I know, you know, represent these numbers. And I'm sure you all are feeling that too. So I just want to say, I hope you all are finding ways to take care of yourselves, and just want to echo that all of us on the presenter panel and at CDC, we care about you and we appreciate all that you're doing. All right, with that being said, can we go to the next slide, please? Okay, I also want to point out what COVID deaths have looked like over time. So again, on the far left, we see that initial peak that was early on in the COVID pandemic around April of 2020. We see the highest number of deaths occurring in that December 2020 to January 2021 frame. And then we see them come down and then go back up again during our Delta wave in August or September-ish. And they haven't really gone back down a whole lot since then. I do want to note that deaths often follow behind cases on a 1 to 2 week lag. So, you know, if we see the peak of cases the first week of the month, the deaths are going to likely peak a couple weeks later. So we can see that deaths are starting to increase again with this current surge, but I don't think we'll know the true number or impact until a couple weeks out. So just want to say, you know, understand this with that caveat in mind. Next slide, please. So here we can really see the rapid growth in the percent of COVID cases in the United States that have been identified as being due to the Omicron variant. And so that makes sense. We know that it's a lot more transmissible than previous variants. And we can see here just how quickly it really took over most of the cases in the United States. There's still about 2% of cases that are due to the Delta variant, and then maybe under a single percent that are due to other lineages. But we can really see that, you know, Omicron is really what we're facing right now. So I think in most situations, we can assume what we're dealing with is Omicron. Next slide, please. Okay, so now I want to quickly recap the guidance updates that my colleague Emily Masitis shared last week. If you weren't on office hours last week, I highly recommend watching that recording for a little bit more of an explanation about what we're recommending. But I think as most of you know, CDC has shortened the duration of quarantine and isolation for the general population. For homeless shelters, CDC recommends a 10-day quarantine and 10-day isolation for clients and staff of shelters, regardless of vaccination and booster status. With that guidance, we also have a statement that says during crisis situations, consult with your local public health to discuss shortening these durations for either clients or staff. I really want to emphasize that, you know, right now, if you are in a crisis situation, what we're recommending may not be feasible. I know, you know, we've heard directly from communities that 10-day recommendation for both quarantine and isolation and for clients and staff just really is not feasible. That so many communities are in crisis mode right now where there are staffing shortages that compromise the safety of operating the facility, or, you know, all of the spaces are filled, the beds are filled, and it's forcing people to have to be on the street or, you know, figure out something else. And that is very much a crisis situation. And And we want you all to know that you should be balancing all of these different risks and considerations with your local public health agency. So the language on that guidance page, it's bolded here on the slide. That's really meant to give local communities some flexibility to adapt to the current needs of your current crisis scenario. I know you all are doing so much for your communities right now, and a lot of you wear many different hats, and we acknowledge that. But if you are finding yourself in a crisis situation and things feel unmanageable and cases seem out of control and it feels like there aren't enough beds, and it just, things really are not working, if you are not already connected to your local public health department, now is the time to do that. Hopefully you're already in communication with them, but if not, those connections are really invaluable because they can help you think through what makes sense for the safety of clients and staff in your shelter. So if, thinking about Detroit and asking this question of at what point do we say this crisis ends or doesn't end, that's up to your local context. But I say that to say you can develop short-term recommendations or adaptations for right now. You don't have to change your procedures for the next 10 months or anything. It can just be, this is what's working right now. Just again, want to emphasize, really think through what the risks are for your community. Communities up north with extreme cold are thinking about hypothermia, where other communities in warmer weather might not be thinking about that at all. Having to bring people in from the cold might warrant different considerations than other health outcomes. So again, really talk with your public health department and think through some of the risks that you're facing. Those of us at CDC, myself included, we're happy to support you and your local public health team if you'd like, but ultimately you all are the experts in your community. And we acknowledge that, you may need to make decisions that differ from other communities too. So you heard from Detroit that they're working with their health department to implement a process that allows for differences by symptoms and incorporates a testing-based approach. But if your community has really, really limited testing resources, that might not work for you, and you may need to think about another way to approach quarantine and isolation. I also want to say that you can consider shortening or adapting quarantine and isolation for clients and staff independently. So if you're like, you know what, we're really up against staffing shortages right now, but not bed space shortages, then you could consider just adapting the duration for staff, and vice versa. So please know that there is some flexibility in that. We know that in crisis modes, a lot of you are going to have to do what is best for your community. So with all of that being said, I hope that gives some peace and confidence to you all to do what's best for you. With that being said, we are holding a webinar next Thursday to review our guidance recommendations. So, what we know as from the science and what we're recommending as best infection prevention and control from the data. We'll be presenting that, but then we will talk through some possibilities for adapting that. And then we're also hoping to have some community features to share how they've adapted either quarantine and isolation space and space utilization or duration for where they're at in their community. So I really, really would love if you all are able to join. It will be a joint feature with our corrections unit as well. But you all are welcome to join. We can put the registration link in the chat. Again, that's next Thursday at 1 p.m. Eastern. And yeah, you'll be able to learn more from other communities as well. So that was a lot. And we'll go to the next slide and switch gears a little bit. A new paper did drop this morning at 11 a.m. It is hot off the press. And it presents findings from an analysis of electronic health records from over 800 hospital emergency departments. So the authors of this study conclude that people experiencing homelessness who were evaluated in the emergency department had a higher frequency of hospitalization and readmissions. So they went to the hospital more often. They had a lower frequency of invasive mechanical ventilation and mortality. So they didn't have to be ventilated as much. And they had longer lengths of stay compared with the general population, which, I think a lot of us maybe knew a little bit anecdotally, but again, we see during COVID that stayed true. The implications of this work indicate that expanding medical respite may reduce hospitalizations or shorten the length of stay for people experiencing homelessness. So it just contributes to the literature about why medical respite can be such a promising practice. And I know some communities who are in crisis situations right now have shifted and are prioritizing their spaces previously used for isolation to protect individuals who might be at high risk for severe illness or hospitalization from COVID as an attempt to try and prevent these hospital stays. So just wanted to put that out there. I know there probably isn't a lot of free time right now, but if you have any, go ahead and take a look at that paper. And with that, we can go to the next slide, and I am happy to take questions.
Great, thank you so much, Ashley. You covered a ton of ground there, extremely helpful. So I do have a few questions that I want to run by you. One person was asking if they don't have testing that's readily available in their community, how do they know when to initiate isolation or quarantine for somebody?
That's a great question. So we're actually working through our guidance updates right now, and in there, it will say either from the date of the positive test if they don't have symptoms, or the start of symptoms that are like COVID-19. So if you have no testing resources, but somebody is like, I have a scratchy throat, I have a cough, I have a headache, I have aches, you know, those classic signs that we're seeing with Omicron, you can go ahead and isolate them or, you know, do whatever you need to do and assume that they're positive if you're not able to test and confirm that. But I did put a link in the chat to a testing resource that is available for homeless shelters, available through a program called Operation Expanded Testing. So if you are having serious testing challenges, you can go ahead and request testing support on that website as well.
Yeah, thank you for pasting that in the chat, and extremely helpful resources for anybody who's running a shelter and needs a lot of testing resources. So another question here is about how would someone know when it's time to initiate an isolation in place contingency plan?
That is a great question, and there's not not one good simple answer. In that case, I would strongly suggest folks, if you're feeling like, okay, you know, we're really out of beds, we're running out of staff, you know, we don't have anywhere to put people, and we're considering isolating in place, reach out to your local health department to figure out ways to do that safely and appropriately. You know, there's going to be different considerations by facility based on the facility layout and the client characteristics and, you know, other things like ventilation, you know, stuff that might not come to the front of mind, but that public health is hopefully prepared to help you with and to help think through what the plan is. So if you're feeling like, you know what, our beds are running out, things just feel really tense, reach out to your public health department and they can help you think through what will work for your facility.
Great, thank you. And one other question that comes from the chat window here is about boosters. So can you talk about how long after someone has had a COVID infection or has been symptomatic, when can they start, you know, getting a booster shot in those circumstances?
Sure. So typically, it's 6 months after the second dose of an mRNA vaccine. That's when you're eligible to get a booster. If you are, you know, you meet that 6 month window and you're like, okay, I'm ready for a booster, but I just tested positive for COVID-19, wait out the recommended isolation period. I think, you know, if you're not having symptoms and you're feeling okay, you could probably go in after day 5 and get that booster. But, you know, we don't want you going to get your booster while you are in that first 5-day window after testing positive from COVID or after the start of your symptoms. So, you know, I'd wait for symptoms to resolve almost all the way, ideally complete in isolation, and then you can go ahead and get your booster.
Yeah, completely makes sense. Thank you so much, Ashley. And if you have any more questions for Ashley, please feel free to type them in the chat window. We're going to move to our next presentation. We have a spotlight on winter planning resources. So I'm going to turn things over to David Canavan, one of our great technical assistance providers, to talk through these resources. David?
Thanks, Norm. And we're giving a bit of a preview on updated winter planning guidance. We can go to the next slide, Micah. But before I do that, I just want to reiterate, this was a slide that we presented last week that really talked about the importance of partnership. And we've kind of gone through another week of conversations with jurisdictions, and I just really want to reinforce that. I sat in on some great calls with jurisdictions that are bringing really creative, flexible teams to the problem that we need to solve today. And having that team structure is so critical. And going back to the beginning of the pandemic, remember we talked a lot about kind of the homeless service system not being a traditional partner of emergency management, or maybe not having robust relationships with public health. And many jurisdictions established those relationships at the beginning of the pandemic. We know there's been staff turnover. We know the tempo of the infections in communities has shaped how individuals have been impacted at the community level with COVID. And some of those relationships may have frayed a bit, or it may be time to renew them. And so this is a great opportunity. We just wanted to really say that clearly. There are lots of great partners in the community that often want to help. Again, sometimes they don't understand the risk context of a congregate homeless shelter. That's not always been on folks' radar as they're making these risk management decisions. And so understanding that it shares some of the attributes of a nursing home in terms of highly vulnerable individuals, while it is a destination for individuals who are discharged perhaps earlier from a hospital because the hospital is using a crisis strategy to manage their beds. And so folks are a bit more ill coming out of the hospitals, and the threshold for inpatient treatment at a hospital may be higher. And so homeless shelters can become a place where risk accrues and compounds in different ways than is well understood by all of our partners in emergency management and public health. So really bringing that conversation to them, and our partners at Healthcare for the Homeless are a vital part of that partnership. And so if you do have a Healthcare for the Homeless grantee in your jurisdiction, really making sure that they're part of helping to articulate the real healthcare component of that conversation, and highlighting the healthcare risks, both at the individual level and the population level. And then again, for emergency management, your COC, your collaborative applicant, perhaps your ESG recipient, can all be good bridges into a conversation with emergency management. And if you are stuck, you absolutely can reach out for technical assistance. That is we're happy to help bridge those conversations where we can. And particularly now with a fast-moving impact that requires a fast-moving solution, and we have somewhat of a clear vision on some of the options, and we'll talk more about that in a moment. And of course, always integrating individuals with lived expertise. These are often the people in our community with the most insight and wisdom around navigating our systems and where there may be blind spots, and integrating these individuals into our planning structures is an absolutely critical priority at every part of our program planning, also in emergency response. And of course, our outreach teams are another great resource for engaging different parts of the community who are accustomed to having access to different resources and can help navigate some of those blind spots well. So if you haven't reached out to these partners and you need some assistance, please do reach out to your technical assistance providers, and through the AAQ or HUD Exchange, or through the chat, or whichever way you'd like. Folks are ready to help. Next slide, please. So I find it helpful to sometimes talk about what can I do today. I think sometimes it can feel overwhelming to undertake big planning exercises. So we really will be, HUD will be releasing guidance documents likely next week around staffing and service shortages. We wanted to preview some of that content here. So understanding that as the crisis impacts and Omicron impacts your staffing patterns, there may be features of your programmatic structure that can be paused while we're navigating this short-term impact of Omicron. And just like we really want local public health authorities involved in those decisions, you all are the ones closest to the work. You know what parts of your programs may be able to be paused, and thinking that through before you're in the thick of this will help your partners to resource some of those parts of your programs that are necessary to sustain life. And emergency homeless shelters, again, as all of you know, really fall into that category of life-sustaining services. So looking at the full portfolio of staff at your programs, how can you retask agency staff that may not traditionally be utilized to simply keep the shelter open? That can include subcontractors like contracted security guards or other different resources that you have available. There will likely be training or checklists that will go with that. So we'll want folks to be thinking through some of those, what decisions may come with those positions. Also thinking through who at your site makes the determination to flip the switch on this approach, and doing some thinking now also with your public health partners around how to do this, how to make that decision. And then, of course, you know, folks have talked about hazard pay and there are lots of ways of compensating individuals who contribute during this crisis surge. And so just really keeping that on the radar. We want to make sure that people feel valued as they are helping us to sustain this life-saving service. Similarly, looking at your food supply plans for our smaller programs, this may not be a feature. For our larger programs, this may be a critical aspect. Again, we want you to think about how to bring some of these questions to partners in the community. Often emergency management has access to disaster feeding contracts or other approaches that can be activated if your kitchen staff are going to be out due to isolation requirements for COVID-19, or your catering vendor is short-staffed and there's going to be a gap and you don't have a good plan B in that situation. Bringing emergency management into that discussion is now's a great time, ahead of the curve, to bring them in if you are not in a jurisdiction where you're already in the thick of it. Calculating the minimum number of PPE that's needed, really being clear that we need access to the right equipment to have folks working in shelters. And CDC, we can put this link in the chat. CDC has a nice what's called a burn rate calculator for figuring out how much PPE your program may go through. And we want you to be engaging our partners, your public health partners and others, as you need these supplies. That, again, we don't have to be the one and only show in town that's resourcing these. We have lots of great partners lifting up these needs. And it's critical when you're lifting up a need, the quantity of the need, the location of it, and the resource that you think addresses that need will help your partners resource you. So I think if we don't give at least a ballpark figure, it's either zero or infinite. And neither one of those planning assumptions is particularly helpful. So if we can narrow the ballpark to tens, hundreds, thousands, that gets us there. If we can get more precise, amazing. But really thinking through some of those definite characteristics of need will help our partners to participate in the response effort with us. Next slide, please. In terms of preventing closure, so we really, and Ashley mentioned in her portion of the presentation, that for folks that are in part of the country where it is bitterly cold today, you know that refusing clients entry into a congregate emergency shelter or warming center is its own threat. And I think that is part of why we have these partnerships, is to really help us navigate these decisions around risk management and decision making. So if you are a shelter program and you haven't worked with your collaborative applicant or your continuum of care entity to really lift up what those needs are for you to keep the shelter open, keep the doors open, then now's a great time to call them today. And start those conversations, get a meeting on the books for early next week. If you're in a COC, if you're one of those collaborative applicants that I just mentioned and you're like, great, thanks, David, reaching out to your municipal partners can be another great an activity for today if they're not already engaged. I know for many of you, this is a repeat of information and you may be well engaged with them, but just in case, we really wanted to lift that up. Also, as we start to think about staffing gaps, that's a planning component that some jurisdictions may not have considered or have a refreshed plan for looking at how to activate staff and volunteer resources. And then, as I mentioned, having checklists or clear understanding of roles and responsibility, particularly if you're going to be activating volunteers who aren't familiar with those roles, really boiling down those positions to the tasks that are essential and being very clear about what those tasks are, so that individuals who may be stepping into those roles without a deep background in shelter management are able to navigate that new role with as much information as we can provide. So we have two documents coming out next week around shelter isolation protocols and staffing shortages. So we'll be looking for those and we'll be presenting on those probably next week as they come out. Next slide. Great. And that, I think, does it for me, Norm. I'll turn it back over to you.
Thanks so much, David. And thank you for your just continued work throughout this pandemic. You and your team have provided some amazing guidance to communities. So we're going to go to our Q&A portion right now. But before we do that, I want to discuss there's an upcoming CARES Act virtual conference. You can see the details here. We'll post the registration button or link in the chat window for you to register for that. This covers ESG CV funding as well as CDBG CV funding. So we'd encourage you, if you're someone who deals with that funding, to go ahead and register for that. And again, it's January 24th through the 28th. We do have some questions that have come in sort of regarding the sort of intersection of ESG and some of these issues we've talked about today. So Marlisa, I wonder if I could turn to you to answer some of these questions. The first one is about someone, if a shelter has someone who's symptomatic but refuses to wear a mask, can a shelter require, when it's funded by ESGCV, can a shelter require that people inside the shelter be wearing masks? Maybe on mute, Marley.
I was. Hi, everybody. I know that this can be kind of confusing because we do have the CARES Act prohibition on requiring clients to complete prerequisite activities as a condition of providing ESG CV assistance, but ESG CV funded shelters can require guests to wear masks. The key here is that shelters must be able to accommodate those who can't wear masks for medical or mental health reasons, and the shelter must be able to provide the masks, meaning you can't require that a guest go get a mask in order to enter the shelter or stay at the shelter. But if a shelter provides the masks for shelter residents, then yes, they absolutely can make that requirement for everyone to wear a mask.
Great. And along a similar vein, another shelter is asking about if they've had people who have refused to test, and the shelter doesn't want to leave people out, especially in cold weather cities, and also you can't deny shelter to someone based on their willingness to test if you're an ESGCV funded shelter. What do you have advice for that shelter provider? How should they handle those kinds of situations?
Well, first, clients do have the right to refuse testing. So it's important to think about alternative referrals. So if there's an alternative place where the client could be redirected, so a warming shelter, an alternative shelter space, that would be ideal. And this is another situation where we're recommending that everyone reach out to their public health partners, because if it's the public health department who issued the binding order, to create that they also are working together with you to create a pathway for people to stay safe and warm, and even if they are refusing to be tested. So that being able to provide alternative shelter spaces for those who are refusing to be tested is equally important.
Great, thank you so much. I think we've come to the end of our session today. I don't think we have any additional questions. I wanted to reiterate a couple things. First of all, the slide up here with the CARES Act virtual conference. Also wanted to reiterate how helpful I think you'll find CDC's virtual conference next week, Thursday, the 20th at 1 p.m. We'll be covering both corrections and emergency shelter situations. So definitely encourage you to go ahead and sign up for that as well. With that, I want to thank everyone who presented today. We definitely want to thank our friends from Detroit for giving a great presentation on some of the challenges they're struggling with and how they're thoughtfully navigating those and creating policies to navigate those. And definitely thank all our other presenters today and our technical assistance team. And once again, I know I say this a lot, once again want to thank everyone who joined the call today. You're doing outstanding work in your communities, and we at the SNAPS team, wholeheartedly appreciate the work you're doing and are constantly amazed and awed by your perseverance and your willingness to just keep going and keep doing better. So we're very big admirers. So with that, thank you everyone for joining. And I want to wish everyone a great rest of the day, great weekend, great Martin Luther King Day next Monday. And that concludes the webinar.